Welcome to today's Explainer. We're setting the stage for a forensic-style medical mystery in the world of veterinary endocrinology. Today, we're looking at a condition that you have undoubtedly encountered, but one that loves to hide in plain sight by mimicking a dozen other ailments. So grab your magnifying glass, because we're investigating canine hypothyroidism. So let's dive right into this massive paradox, shall we? Why is the absolute most common endocrine disease in dogs also the most overdiagnosed? I mean, how can something we see so often be gotten wrong so frequently?
Well, the answer lies in what we call a classic clinical trap. It's a combination of nonspecific signs plus incredibly easy to misread blood work. It's literally the perfect disguise. This trap easily ensnares even the most seasoned veterinarian detectives. The symptoms whisper, the lab results outright lie to you, and before you know it, you're treating a disease the dog doesn't even have. To get to the bottom of this, here's our game plan for today's Explainer. We'll start with the ultimate clinical trap, move into spotting the true symptoms, then solve the diagnostic mystery, and wrap up with treatment protocols and pitfalls. Let's get into it. Starting right off with part 1, the ultimate clinical trap. Okay, so the most vital piece of this puzzle is the overwhelming dominance of primary hypothyroidism. We're talking a staggering 95% of cases being primary, which basically means the thyroid gland itself is actively being destroyed. This usually happens in one of two ways. You've got lymphocytic thyroiditis, which is an immune-mediated infiltration that literally destroys the follicles and causes fibrosis. Or you have idiopathic thyroid atrophy, where the working tissue is just quietly replaced by fat. That remaining tiny 5% slice, that represents your rare secondary or congenital causes, like pituitary tumors or dwarfism. And as for when this destruction typically strikes, it usually hits dogs right in their prime, somewhere between 4 to 10 years old.
Moving on to part 2, spotting the true symptoms.
First up, who exactly is at risk here? Well, it doesn't really care if the dog is male or female. They're equally targeted, but it definitely has a type when it comes to size. Mid to large breeds are disproportionately affected. Breeds like the Golden Retriever, Doberman Pinscher, and Irish Setter are frequent victims. But hey, don't let your guard down if you see a miniature Schnauzer or a Dachshund Waddle-in, because they are highly predisposed too. So what are the clues we're actually looking for? We generally group them into metabolic and dermatologic signs, which you'll see in about 2/3 of cases. Metabolically, you'll see profound lethargy, mental dullness, and a dog constantly seeking out heat. Crucially, and this is a big one, they'll pack on the pounds without any increase in their appetite whatsoever. On the dermatologic side, look for a dry coat, excess shedding, and that classic bilaterally symmetric non-pruritic alopecia. That's a fancy way of saying hair loss on the trunk or tail that absolutely does not itch. You might even notice some dark hyperpigmentation on the skin. These are your classic, textbook clues that should immediately raise your index of suspicion. Now, these clues can build into one of the absolute most memorable visual signs you'll see in moderate to severe cases, myxedema. This is where the face becomes noticeably puffy, the skin folds thicken up, and the upper eyelids droop. It creates what is famously known in veterinary medicine as a tragic facial expression. Honestly, if you see a dog looking profoundly, structurally sad, myxedema should immediately cross your mind. But before we completely close the book on symptoms, we've got to talk about the uncommon ones. Intact dogs might show reproductive issues, think anastress and infertility in females or low libido in males. Neurologic signs can also pop up out of nowhere, like megaesophagus or facial nerve paralysis. And it's super important to know that those neurologic signs might not actually resolve even with thyroid treatment. Finally, there's the incredibly severe, though rare, myxedema coma. If you see stupor and profound hypothermia, that is an absolute drop-everything emergency.
All right, part 3, solving the diagnostic mystery.
Listen, if you take nothing else away from this, remember this golden rule. A low total T4 alone does not equal a diagnosis. Total T4 is a fantastic first screen because it has a really high sensitivity, around 90%. But its specificity is frankly terrible. It gets easily suppressed by non-thyroidal illnesses or even just daily medications. Instead, you really need to rely on free T4, specifically measured via the equilibrium dialysis method. Free T4 gives you a much higher specificity, and it's far less affected by sick euthyroid syndrome. It is a way more reliable forensic tool to have in your kit. Now, I know what you're probably thinking. Hey, I'll just run a TSH level to confirm, right? Well, be really careful there. 20 to 40% of confirmed hypothyroid dogs have a completely normal TSH. It has low sensitivity, so it should absolutely never be interpreted completely on its own. What you can also look for are TGAA, or thyroglobulin autoantibodies. They show up in up to half of hypothyroid dogs, and if they're present, it heavily supports a diagnosis of underlying lymphocytic thyroiditis. Okay, let's actually slow down for a second here, because we really need to talk about the massive red herrings that lead straight to misdiagnosis. First up, we have the breed traps. Sighthounds, your Greyhounds, Basenjis, Salukis, Whippets, and Scottish Deerhounds, they have naturally lower baseline T4 and free T4 reference ranges. If you judge a Greyhound against a Golden Retriever's chart, you're going to diagnose a disease they just don't have. Then we've got the drug traps. Super common medications like glucocorticoids, phenobarbital, sulfonamides, and furosemide will heavily suppress thyroid values. You must always audit your suspect's background. So to really build confidence in your diagnosis, you want to look for supporting background evidence on a standard blood panel. About 40 to 50% of these cases will show a mild normocytic normochromic non-regenerative anemia. But even more strikingly, roughly 80% of cases feature hypercholesterolemia. A high cholesterol flag on a lethargic dog, that is a classic ClinPath clue that should absolutely point your magnifying glass straight toward the thyroid. And that brings us to our final section, Part 4, Treatment Protocols and Pitfalls.
The fix here is lifelong oral levothyroxine, and the standard starting dose is 22 micrograms per kilogram given every 24 hours or divided twice daily, ideally on an empty stomach. But here's what's actually kind of funny about this number. The canine dose is massively higher than the human dose. You genuinely need to warn your clients about this, because human pharmacists frequently see this giant prescription, assume it's some sort of dangerous error, and try to question or misfill it. Once you start treatment, you really have to set clear expectations with the owners about the timeline of the clinical response. Usually within the first 2 weeks, you'll see that lethargy and mental dullness start to lift. Then, around the 4 to 8 week mark, that's when you want to schedule follow-up therapeutic monitoring to check those peak and trough T4 levels. But definitely warn the owners. Those dermatologic signs, the hair regrowth, and the weight loss, that can take up to 3 incredibly long months to really visibly improve. Patience is absolutely key here. Let's actually take a super quick detour just to contrast our dog patients with cats. Canine hypothyroidism is naturally occurring and, as we know, very common. Feline hypothyroidism, on the other hand, is exceptionally rare to see naturally. When you do see it in cats, it is almost always iatrogenic, meaning it was caused by us, usually after radioiodine therapy or a thyroidectomy for hyperthyroidism. The two species literally couldn't be more opposite in this regard. All right, jumping back to dogs, we've got to face what happens when things just go wrong. If you are over-supplementing, you'll see thyrotoxicosis signs, panting, nervousness, a racing heart, PU/PD. But if the dog simply isn't getting better at all, and their T4 levels actually look great on paper, you have to face a really tough truth. Misdiagnosis is literally the top cause of perceived treatment failure. Which leaves us with this final, somewhat provocative question to rethink how we approach this sneaky disease. If your patient's symptoms are hanging on despite treatment, do they actually need a higher dose, or do you need an entirely new diagnosis? Just remember, a low T4 does not equal hypothyroidism by itself. Stay vigilant out there, watch out for those red herrings, and don't fall for the great clinical trap. Thanks so much for joining me on today's Explainer, and keep learning.